Well, welcome back everyone from lunch. I hope you are feeling satiated but not too sleepy. I'm sure we're catching some people in the jet lag slump, but I promise you that this session will be suitably entertaining and keep you riveted. We are going to spend the next hour and a half focusing on a number of examples of really good practice models for HPV-related cancer elimination, and the first presenter is going to come to us through a pre-record, and that is Dr. Nelly Mugo. She's a reproductive health specialist based in Kenya, where she runs a clinical trial site and was in fact the protocol co-chair for the Kenya HPV single-dose vaccine study, or KENSHI, that was mentioned in the earlier session. And so she's going to be sharing with us the latest evidence related to single-dose efficacy.
Good morning, good evening to all the session participants, wherever you might be. I'd like to start by thanking IAS and the session organizers for inviting me to this session to present our data on the latest evidence from our KENSHI study. This work has been led by the protocol chair, Juan Barnabas, and a team of scientists. My disclosures that I have received research funds from MAC Investigator Initiated Studies grants. So the study that will be presented, called KENSHI, is a randomized trial of single-dose vaccination efficacy among young women, and I'll be presenting the data from our final efficacy results. This work has been made possible by a strong team of scientists led by Professor Juan Barnabas from the Massachusetts General Hospital, by my colleagues at the Kenya Medical Research Institute and Ministry of Health, by colleagues from University of Washington and the Fred Hatch. So in background, we have data from clinical trials that has shown across multiple geographies and studies that single-dose HPV vaccination works in protection against HPV infection. Part of that data was presented from the KENSHI trial at our 18-month follow-up. Then we have the DORIS trial, which was amongst young girls ages 9 to 14, looking at immunogenicity across the 3 doses of 1 dose, 2 dose, and 3 doses, examining the nanovalent and bivalent vaccine. Then we also have observational data from 2 studies. One is the IRAC study done in India, has presented 10-year follow-up data with an outcome of persistent HPV infection and pre-cancer lesions, and they've been able to show 95% protection from HPV 16 and 18 with single dose. Similarly, the Costa Rica trial CVT using the bivalent vaccine has presented 10-year post-vaccination data, and they've been able to show protection again from infection and pre-cancer lesions with 1 dose compared to 2 doses and 3 doses. So the data I'll be presenting is from, as I mentioned, the KENSHI study. And the KENSHI study enrolled 2,275 young women ages 15 to 20 years. They were individually randomized, double-blinded, controlled trial. One group received the nanovalent vaccine, the second group the bivalent vaccine, and third group recipients received the meningococcal vaccine. We presented results from 18-month follow-up, and we were able at that time to show 98% vaccine efficacy for HPV 16 and 18, and 89% vaccine efficacy for HPV 16, 18, 31, 33, 45, 52, and 58, which cumulatively are responsible for up to 90% of invasive cervical cancer. Now, today, it's my pleasure to share with you the results at month 36 of follow-up. Now, we followed these girls for a total of 36 months presently, and we've been collecting cervical swabs for HPV DNA every 6 months. But the importance is that this trial this trial did not observe any adverse events that were assessed as product related. Of equal importance is the pregnancy rate. About 5% across the study arms were pregnant, though we provided on-site contraceptive products. To further show equality in the randomization is that the characteristics of this cohort was similar across the 3 arms. The distribution by age of young girls 15 to 17, though all around the median age of 17, about 3/4 had secondary school education, had steady partnership was 70%, and that chlamydia prevalence was around 12% across arms. The incidence of non-vaccine HPV types, again, was similar across the 3 arms, demonstrating equal exposure to STIs across the study arms and possibility of HPV infection. So I'll be presenting the final efficacy results at 36 months. And we're very pleased with these results. We're able to show that at 36 months, a single dose of HPV vaccination has 98% efficacy to prevent persistent HPV 16 and 18 infection if vaccinated with nanovalent or the bivalent vaccine. And you can see the confidence intervals are very tight between 91 and literally 100%, and similarly high for nanovalent. This graph also shows that the infection with HPV 16 for the meningococcal arm was continuous through the duration of follow-up. But in the vaccinated groups for bivalent in red dots and nanovalent in blue line, did not increase through the 36 months. When we look at 36-month efficacy rate in prevention of persistent HPV 16, 18, 31, 33, 45, 52, and 58 infection, we were able to show 96% effective protection from those infections. Again, this graphic chart shows continuous infection through the duration of follow-up for the meningococcal arm cohort and a flat line for the nanovalent vaccinated cohort. We did additional analysis, and we looked at participants who had HPV antibodies at enrollment, meaning they were previously exposed, and then we looked at participants who did not have HPV DNA by month 36. And you can see that amongst participants who did not have HPV DNA at month 36, meaning that they were not pre-exposed, and remember this is a prophylactic vaccine, we did not see any HPV incident, persistent HPV 16 and 18 infection for both the nanovalent and bivalent vaccine. For the participants who had HPV DNA at enrollment, we saw a few, but the efficacy rates were extremely high at 99% protection. Then we now looked at this extended sensitivity analysis for the 7 types again that cause 90% of invasive cervical cancer. And when we looked at those who did not have HPV DNA at month 6, it was 99% efficacy and 95% if they had HPV DNA at the time of vaccination. So Kenshi study has shown very high efficacy of more than 95% of a single-dose HPV vaccine. This supports the WHO policy change recommending single-dose HPV vaccination. We continue to follow up this cohort. We vaccinated everybody in the meningococcal arm received the nanovalent vaccine, and we continue to follow up for durability. This work has been made possible by the efforts of a large community of scientists and the study participants who've been highly dedicated and shown very high retention to study procedures and visits. We dedicate this work to our mothers and all the mothers in the world, to the study sponsors and our institutions that have supported this work. So on behalf of the Kenshi study team, I thank you.
She's not live. So really important and influential results that really kind of helped move the policy around single-dose vaccination forward. We're now going to shift gears a little bit and focus on screening strategies, and it gives me great pleasure to introduce Marianne Saville, who's the Executive Director of the Australian Centre for the Prevention of Cervical Cancer. And Marianne is going to focus today on person-centered care approaches for HPV testing and task-shifting opportunities.
Thank you very much, and you very much have the understudy today. This is work that has been undertaken in Malaysia, mostly led by Prof. Yinling Wu, who is actually in Sarawak today, and they're out screening women, and supported very strongly by Prof. Adiba, who's here today, and is, of course, Chair of the Board of Trustees. This work has been a collaboration and a partnership which started in 2017. But just to get to the point in the interest of time, when we started talking, Yinling was telling me that fewer than 1 in 4 women were accessing the free Pap smear program that was available in Malaysia. And it was partly through lack of access, but also sociocultural factors that were preventing women from getting screened. Recently, Malaysia has changed its guidelines to primary HPV screening, and that transition is underway and will take about 5 years. So ROSE, which is Removing Obstacles to Cervical Screening, was a project that grew out of this collaboration. And on the left here, you see the planning and the whiteboard where we mapped through the patient journey, presenting for screening, getting screened, getting the result, how we would get the result to her. And on the right, you see the doodles that Yinling did in coming up with this name of Project Rose. It was really important that while we were bringing some laboratory and digital health expertise to this project, that we knew that we needed to hear from Yinling and colleagues in Malaysia about what would work in that setting. And so what we came up with was this process whereby we used HPV self-collection. We used a clinically validated test, and that has now, a lab has been set up, as you'll see, that's quality assured in Kuala Lumpur. And we used a digital health platform called CanScreen. So using this platform, the people facilitating screening could use their mobile phones to collect the demographic and contact information, and we could join that up with the test results back at the lab. And then the ROSE team runs this contact centre that uses CanScreen to know who they need to contact to ensure follow-up. So what was in our minds from the very beginning is we needed to use the right test, and we needed to have a screening pathway. So HPV screening as an activity will not deliver outcomes unless you have linkage to care and effective treatment of pre-cancer, and ideally cancers as they are identified as well. This is CanScreen. It enables us in the Azure environment. It's highly secure, and it collects the identified information about people and their screening activity, and it facilitates that follow-up activity. We have cervical screening registers in Australia for a very long time. We understand how they work. However, still in Australia, we are contacted only at the moment by letters through the mail, and that clearly was not going to work in a country like Malaysia or many low and middle income countries. We started by communicating with women with SMS reminders, but Yinling came to me after a couple of years and said that works in the short term, but there's quite a lot of churn. So we've now adapted CanScreen, and the messaging is largely through WhatsApp. So I think we need to continue to improve and modify the way we're doing things to meet the local needs. So this really was a story of collaboration, and I feel like it's a scaffolding. We were very intensively involved from Australia in supporting the technical side of things. But as you'll see, the team have taken this and run with it, and I'm so proud of what they have achieved. In the middle there is David Hawkes. He's my molecular microbiology person, and he's been up there assisting with the delivery of the platform and instrument, and has been assisting with the commercial negotiations with the manufacturer as well. And down there, Rena, I can see that you were involved and some other staff. So it was a busy time for the first year or so, and a lot of trips to KL and some trips from KL down to Melbourne where we're based. The team take make good and make do approach to setting up community-based screening. So the screening has taken place in healthcare settings, but lately more commonly in community-based screening settings, and they're just looking for somewhere private so that women can collect their sample, and they just make it work, and it's a different set of pictures on every screening, and it's just amazing. And here you see the education of the woman who's about to be screened is being supported by someone who's training on the other side, holding up the messages to make sure she goes through them. This team, they're so innovative in solving problems on the day. So after an eligibility check, which is mostly around age, and because these women are linked to colposcopy for their triage, they are screening slightly older women. So they're aiming to get women 30 to 49, but they will take women up to 59 because there has been no screening and because they have got the opportunity to follow them up. There's then the education, there's the registration onto CanScreen, getting all the details, and then the sample collection. It's taking place in a range of community settings here, in religious centres, in very remote settings, and that's where the teams are at the moment. They address issues as they come across them, and they are screening a large number of people who really need screening, including Indigenous communities, people living with disability, and people from a variety of cultures and faiths. So the management of screen-positive women happens from KL, communication, as I said, through WhatsApp, and then you'll see there that the participants, if they get a positive result, they have the opportunity to call in and make an appointment. And then there's a cascade of things that happen if they don't get in touch with a woman, and they work very hard to bring these women to colposcopy for follow-up care. Yinling has set up this most amazing network of hospitals that will see these patients, and so anywhere they go around the country, they have to have set up a colposcopy service in advance to see these patients. So as of April, we're just over, I think, just over 23,000 women screened since inception, and more than 9 in 10 are navigated to care and colposcopy. And of course, there are always those who are waiting for their services. So I just want to say that this has been the most amazing project and a privilege to be involved in it. You can see there that it has been such a collaboration, and I think those of us that have had the privilege of great government funding, we have our challenges here with some communities that are not well screened and not well served. But I think we owe it to the countries in our region to partner to help deliver things. And I think it's been so critical to understand we are not experts in other people's countries, and we need to work in partnership to design solutions for screening that will work. And no screening without follow-up, otherwise you're not going to move the dial. So thank you. Not a data-heavy presentation, but it's been a fantastic story to be involved with. Thank you very much.
Thanks so much, Marion, for sharing those really impressive results. I'm now going to hand over to Professor Andrew Vallely, who is a clinical epidemiologist at the Kirby Institute, and he currently leads the Eliminate Cervical Cancer Across the Western Pacific program to advance elimination of cervical cancer in Papua New Guinea, Vanuatu, and the region. And he's going to share some updates with us.
Thanks very much, Sinead. So first of all, I just want to say that I'm sadly Dr. Paulus Reaper, who's a very close friend and inspirational colleague, was unable to join us today because of problems with his. He couldn't quite get his flight was cancelled basically from PNG. So, but I'm really presenting these data as in a similar vein to as Marion said, on behalf of some really inspirational leaders and colleagues in the region, particularly Paulus, also Jane Holden in Western Highlands Province in Papua New Guinea. In addition to Paulus, Dr. Boniface, Demutalau, Margaret Terehe in Vanuatu, and of course my co-leads, who has been the co-leads in Australia, who's been a true privilege and honour to work with, and I've learned so much from, particularly from Karen and also from Marion, and also our other great colleague, Deborah Bateson. And we're very, very fortunate, all of us, to be supported by a wonderful team, including Vanessa Price, Misha Coleman, Paul Grogan, and Tim Belshaw. So with that, I should actually get on with the presentation, because I've probably used more time than I should have done, but anyway. So the program, I don't really have any, it's down there, interest to declare. So the program itself is a landmark investment, really. It's a collaboration. It's incredibly exciting. I get very excited by it. We all do. It's a combination of philanthropic funding, biotech partner and industry donations, development partner and government in-kind contributions. And really this brings together more than $30 million Australian dollars worth of funding to advance the elimination agenda, initially in PNG and the Western Highlands of Papua New Guinea, and also across Vanuatu. But the program is designed to be open-ended. It's designed to advance. It's designed to move forward. We're already engaged with a number of other provinces in PNG. So this in Western Highlands is directly funded and supported through this program. We have 6 other provinces that are coming on board, we hope in the very near future. And it's a really, really exciting opportunity to advance the 90-70-90 targets and to really move forward together. So the program itself is built on 6 outputs. The first 3 reflect the 70-90 targets, and the next 3 really are the foundation on which they're built. So these targets are, and these outputs are around establishing the kind of registry platforms that Marion has just described that have already been established in Malaysia, and we're doing that, doing something very, very similar in PNG and Vanuatu, to build the essential quality management and training systems that we need to go forward, and then to obtain the essential economic and social health system and policy data to really try and drive sustainability, to keep this program moving forward. So with vaccination, we're very fortunate in Vanuatu that there was a very substantial program through a middle income country initiative funded through ADB and supported through UNICEF. That program has now started, so the HPV vaccine rollout is now starting, and it's already started in 1 province. They're just about tomorrow to start in a 2nd province, so this is really starting to advance. And in PNG, as part of the program, we are securing additional funding to support vaccine procurement and to move forward with the start, hopefully in the 1st quarter of next year, with the introduction in Western Highlands. And for those 2 programs, the target for each are 30,000 girls aged 9 to 14 who receive the vaccination between now and 2025. And I just want to talk a little bit, I've spent a little bit of time talking about the screen and treat program. In both countries now we've established clinics in one fixed facility in Mount Hagen in Papua New Guinea. In Vanuatu, we've actually established 2 screening hubs and have started to conduct outreach from those, and around 10,000 women have been screened in the last year across the 2 sites. Oh, I'm not pointing that the right way. Oh, yeah. So the program is based on point-of-care screen and treat, self-collection for vaginal specimens at point of care, tested on the GeneXpert platform. Women who test positive are offered same-day visual assessment to assess their eligibility for thermal ablation, and then are either provided with thermal ablation or referred for specialist review. And we have built in the same register, it's been adapted to the local setting for PNG and Vanuatu, the same register that Marion described, to enable us to provide this screening program at scale in both countries. This program is built on the evidence that we have collectively in our group been working on for the last 10 or more years, close to 15 years now. Firstly, demonstrating in 2 large-scale field trials in Papua New Guinea the effectiveness and safety of this intervention, with over 90% sensitivity for the detection and treatment of high-grade disease on the same day. We've demonstrated its cost-effectiveness, the Royal We, as Karen and her group, demonstrated the cost-effectiveness and estimated the substantial population impact of this approach. And we've also shown that this is highly acceptable, highly efficient within the context of primary healthcare delivery in a low middle income setting, and very, very much so scalable. And this has led to the program and these guidelines being adopted in both countries, in Papua New Guinea in December 2021 and Vanuatu in March of last year. We follow a hub and spoke model in both settings, establishing a central center and then with outreach to those to other sites. And here in Papua New Guinea, you can see we've established a mobile truck that goes out into the community. The demand has been absolutely overwhelming. We had 400 or 500 women turn up on the first day when the truck went out, despite trying to target the mobilization and not have everybody from all the surrounding communities come. But the demand is enormous. In Vanuatu, we have 2 hubs, one in Port Vila in the south, another hub in the north. And we've used a combination of fixed facility, mobile outreach by truck, and most recently offered a space and berth on a vessel, a health boat called Helper One, which went out to visit some of the most remote and difficult to reach settings in the country, which has been fabulous. And that picture on the right is actually within the boat, would you believe? Not in the clinic, because actually we set up 3 GeneXpert machines. We're able to do the testing and treatment and provide this service in the most rural settings you can probably imagine. We're working also very hard to support and strengthen histopath services, diagnostic imaging, to support South-South collaboration in the establishment of large loop excision in both countries and in other countries. And Marion in particular and others in our group participating and supporting an upcoming impact mission to look at and mapping cancer services in PNG. We've been very, very fortunate in having an incredible, a really incredible registry platform to support the program and being able to adapt this to the local setting, both in PNG and Vanuatu. And we've been also very, very fortunate in working with one of our other partners, I haven't mentioned, Family Planning New South Wales, who have conducted Train the Trainer and other clinical training activities. And that's enabled us to transition all of our training now to a locally led model with our own trainers in country now leading on the training and providing that support for the staff. And then finally, and largely led by Karen and her team, we've been able to not only support the development of the Wipro strategic framework in cervical cancer elimination, but also to develop elimination planning tools, as Karen touched on earlier, and also working together, all of us, we are supporting both countries in moving forward and developing their national elimination strategies and plans with an upcoming meeting in Vanuatu in October. And finally, I'd just like to acknowledge an enormous number of organizations. We've already thankfully managed to acknowledge the incredible individuals and colleagues that have been so inspiring and provided such incredible support. And thank you all very much.
Thanks so much, Andrew. We're now going to hear from Eric Fleutelot, who is Technical Director of the Major Pandemics Cluster of Expertise France. He also manages the Success Program for secondary prevention of cervical cancer in 4 countries, supported by UNITAID.
Good afternoon. Thank you very much. And it's really a pleasure for me to be here with you today. And I'd like to thank the organizer for this opportunity to present our experience from the Success Project. Is it here? This one? Okay. I have a lot of interest in the topic, but I don't have conflict of interest. The Success Project focuses on integrating HPV testing and treatment of precancerous lesions with thermal ablation into the existing health system. And we do that with the funding from UNITAID, mainly, but with also some additional funding from the French MOFA and the French Ministry of Health. Success is implemented in 4 countries. Côte d'Ivoire, Burkina Faso, West Africa, Guatemala, and the Philippines by a consortium of partners, including Expertise France, GPIGO, and UICC. And we have also some scientific support from INCA France, INCA Brazil, NCI, and NCC. Integration is the key word of the Success Project. And to achieve this, we have been working on the main pillars of the health system. Starting with leadership and governance, of course, as implementing a cervical cancer prevention program requires the support of all relevant national key stakeholders. It also implies the development and/or the revision of the national cancer plan and guidelines in order to reflect the WHO recommendations, including the recommendations specific to women living with HIV. And we strongly believe also that cervical cancer prevention must be integrated into HIV strategic plans and national guidelines. So it's a shared responsibility between national HIV program and national cancer or national non-communicable disease program to achieve the elimination of cervical cancer. The second pillar we were working on is the health information system. It's a significant component when it comes to monitoring and patient follow-up. It's key to ensure that the provision of service is part of the continuum of care. For example, in Burkina Faso and in Côte d'Ivoire, Success has been working with DHIS2 tracker to digitalize cervical cancer patient navigation and to ensure the timely return of HPV test results. Advocacy should be also made to support the integration of cervical cancer indicators and linkage with HIV indicators in the national health information system. The third pillar is financing. To obtain the appropriate funding, countries need a clear view of the cost to implement a cervical cancer secondary prevention program. So through the Success Project, we support costing exercise by using the C4P tool that was initially developed for WHO and that we updated for the project. There's a very suitable source of funding, and I'm very happy to see that Lady Rose just entered the room. There's a very suitable source of funding. It's worth mentioning, I think, for eligible countries. It's the Global Fund Against HIV, TB, and Malaria, since activities on HPV, especially for women living with HIV, but not only, can be supported by Global Fund grants. The fourth pillar is access to health products, which include supporting procurement and supply chain management through central medical store, optimization of existing laboratory platforms for HPV testing, introduction of HPV testing products and thermal ablation devices in countries, and of course, an efficient sample transportation system. The last pillar, obviously, it's human resources. It's always a key component for everything, but it's also the case for integrated service delivery. As HPV testing and thermal ablation were new services. Training modules were developed in collaboration with ministries of health, and supervision and training was provided in each country to health professionals. Mentoring and supervision must be part also of the program to reinforce health workers' skills in screening and treatment. Last but not least, service provision, which includes also raising awareness, demand generation, and national advocacy. Exploring the integrating model of service delivery tailored to local context is also within this pillar. Service provision, according to our experience in the 4 countries, should also be based on evidence on feasibility, acceptability, and costing. And I very much not sure. I'm lost, maybe. Oh, I'm not that lost. Okay. I very much like to use examples. So let's take the one on integrating HPV screening services into HIV clinics. So WHO recommends that women living with HIV aged 25 to 49 years old should have access to HPV testing every 3 years. For these women living with HIV to access screening, we need multiple entry points and a strong demand generation through various channels. Community health workers will be a great asset for the sensitization and engagement of women. HPV testing should also be integrated into the patient follow-up and monitoring systems already in place in HIV clinics to reduce the risk of loss of follow-up and to improve the continuum of care. So we should avoid to build something parallel. It should be 100% integrated. And as I told you, integration must be part. Integration must be based on evidence, and as part of the success project, we are currently conducting an implementation research in the 4 countries I mentioned before. The goal is to assess the feasibility, the acceptability, and the cost of integrating HPV screening and treating precancerous lesions with ablative treatment into already existing health services. So the research aims to answer the 4 questions that you can see on the slide if you can read these very low cases. In each country, 10 study sites were carefully selected to enroll 2,227 women for HPV testing and treatment if needed, including 12 months post-treatment follow-up. The research is still ongoing, and you will find the preliminary results on one of our e-poster who is going to be published during the conference. Sharing experience and learning from others could also be beneficial when implementing a new service delivery. So that's why we set up a regional dialogue on women cancer for Asia Pacific. It was organized very recently in Manila, and we did the same for West and Central Africa in Abidjan, and another one for Latin America in Rio de Janeiro. So mobilizing key partners for HIV responses is also essential to reach women living with HIV. So we are currently working on an extension of the Success Project with co-funding from UNITAID and from l'Initiative, the French set-aside to the Global Fund. L'Initiative, by the way, is also providing technical assistance in some countries, like in Vietnam or in Cambodia, for cervical cancer prevention. And we set up a toolkit with a lot of documentations to explore different avenues to initiate or accelerate the fight against cervical cancer and to integrating it into the HIV response it was done specifically for programmatic experts working on the GC7, so the funding request to the Global Fund, so countries can secure that they have enough funding for the coming years to support these new services. In conclusion, there are several pathways already existing to improve further the health of women living with HIV, so that they are no longer the ones most affected by this preventable cancer. I would like to thank the team of the Success Project, including our colleagues from GPIGO and UICC. I would like also to thank you for your attention, and just do not hesitate to reach out to us. You have the email address of the Success team, and you can also follow us on Twitter. Thank you very much.
Thank you so much, Eric, for those important messages about integration. I now want to introduce Lance Osiro, who is a public health professional from Nairobi, Kenya, and he currently works with the Clinton Health Access Initiative. And he is going to speak about the role of HPV testing and secondary prevention in Kenya.
Thank you very much. Good afternoon. Yes, so I'd like to briefly just go through our project, which was supported by United, the collaboration between United and CHI. Oh, sorry about that. Yeah, so it was focusing on the introduction and scale-up of cervical cancer screening and treatment in terms of introduction of screening through molecular HPV and treatment through thermal ablation and treatment of precancerous lesions. The project took 3.5 years. And yes, moving on, I have no conflicts of interest to declare. And so I'll focus on 4 major buckets. We look at the background, you look at the interventions that we've done, and then also we look at the approaches that we took and the key challenges from our work. So looking at the background, we saw in the previous presentations that Kenya, being part of the LMICs, is a high burden of cancer, and it's amongst the 20 African countries which has the highest burden. This looks at about 5,200 new infections, which now are against the background of 3,200 deaths that are reported every year. And against this background, we see that at the same time we have a very high HIV burden, looking at 1.4 million people living with HIV in Kenya, and about 78%, which reflects about a little over 1 million people who are on treatment in about 3,800 ART sites, and 65.4%, about 700,000, are women living with HIV. And this was one of our entry points in terms of targeting these women in terms of screening. And as even mentioned before, we look at the co-infection between HIV and HPV. We see that these women are at a higher risk, about 5 to 6 times at a higher risk of acquiring HPV infections. And Kenya, being part of the other countries which heeded to the call to action by WHO in the elimination strategy for the approach of the 90-70-90, looking at now tackling the secondary prevention. And this just looks at the introduction of HPV testing as a primary way of testing, followed by V as a triage, and also focusing on the single visit approach. This is very classical in the LMSs because there's a very high chance of loss to follow-up. And through the implementation of this program, we looked at, we saw that at the beginning of the program, we had about 90% screening coverage. And by the end of the 3.5 years, we were able to scale up and reach at about 46% of screening coverage. Looking at also the treatment in terms of the facilities offering these services, which was up to 18%. In terms of Yes. So in terms of how we're able to look at this, it was like we had to sit down, and we have this investment made by United, and through this collaboration, we're able to select the HPV sites that we're able to tackle and introduce this mode of testing, and able to look at 31 sites which were able to introduce integrated services. And through these 31 sites, they spanned in about 25 counties, the geographical locations that we're able to implement. And we saw it was very, very prudent, not only to look at these 31 facilities, but then to look at the other facilities in these 25 counties, and able to reach out to that. And even just mentioning back to the 31 facilities, 25 counties, our entry point was looking at the HIV burden in these counties, because of the obvious reasons in terms of the relationship between HIV and HPV. And looking at that, we were looking at how effective would our interventions be, looking at things to do with the scale of impact, the breadth of this impact, and the longevity, or rather the sustainability of this impact. Because these 25 counties, we are having over 60% of the facilities which were public health facilities. We're looking at these 25 counties had the highest population of the cases of cancer, both precancerous lesions and the suspicious cases for cancer. And also it was a mix of urban and rural population, dense population and sparse population. And this was just able to help us to be able to implement this and to reach out and offer these services to them. And over and beyond that, we're able to decentralize these services, because this was key in terms of interventions and in terms of reaching out to many people, to decentralize screening services, treatment services, and even the referral and follow-up. And one of the key things that was very, very evident here was the integration part of this. Integration part of this, and through this, we're able to offer integrated care. At these facilities. And number one thing was now we targeted the ART sites through the CCCs, which means the comprehensive care clinics. I'm sure it has different names in different settings. So, and through targeting these CCCs, we're able to issue them with the HPV kits. And this approach had two approaches. We had the point of care facilities, and then also we had the conventional testing in some of these facilities. And through this, we're able to reach out to them, and also amidst of all this, we're able to work closely with different organizations. These are the CSOs, the key opinion leaders, and different partners, just to foster demand generation and sensitization of these services. Number two was these sites were able to leverage on the already existing structures through the HIV program. So this looks at the human resource for health. We're able to train and capacity build the same staff who work there, the transport networks which were already available, the reporting platforms, and this we trained the different nurses, the medical officers, the clinical officers, the transport, the relaying back of the results back to the patient, and also in the official reporting system, the LIMS reporting system that the HIV and the TB program was using, we're able to incorporate the HPV aspect in terms of that. Last but not least, we're able to do follow-up and linkage to care through phone calls, SMSs, and even through the HIV networks that were available. So through implementing of this, we're able to see some successes. And at the same time, we had some challenges, but then we were able to look at the different challenges. For example, we had logistical challenges in terms of the screening commodities. So at the beginning of the program, the CHI used to manage the logistics in terms of procurement, distribution to the facilities. But then moving forward, working through the Ministry of Health, we have been able now to capacity build the National Procurement Agency to be able to handle any commodities which are coming in, whether it's the reagents, the commodities, or thermal ablation. And a good example is we had additional investments through USAID, and MOH was able to use KEMSA to do the logistical work in terms of that. Capacity building challenges, we had that because the result of turnover which happens in the health facilities, I think it's very classical in many of our settings. And so able to train at least 2 people per facility in terms of that. And just to add on to that, we're able to offer mentorship and supervision. At the same time, doing on-job training for the staff who are there. And then things to do with reporting tools, we're able to revise the tools which were there before in order to capture some of the indicators that we needed to capture. And then also navigating through the different programs and facilitating the integration between the programs. And something else which was classical when implementing was that the COVID pandemic hit overlapping when we're implementing. And so because of the limited access to the facilities, it was because people never got get to the facilities, then we're able to pilot the self-sampling approach, which was very, very successful in that. And last but not least, we look at some of the key enablers that I've mentioned before: capacity building, use of the community strategy, self-sampling, collaboration. And through this, all this, we're able to increase the sites which are offering up to 3,120 sites offering integrated service delivery. We're able to screen many women, up to a little over 1,000. 1 million women screened through VIA and HPV, and 20% of the public health facilities were able to offer these services. And just some of the service delivery areas: we have the lab, we have the health education, and some of implementation. And back to the right, we have, to the far right, we have the policy documents that were able to help us implement these activities. And just by that, we have to show appreciation for our donor. We have UNITAID, we have Ministry of Health, NCCP, and KEMS and the county governments. And just in summary, I just like to call my colleague Gerald, or I just continue. So in a broader term, because this was implemented in 10 other countries, that we had similar approaches in terms of that. We had Kenya, Rwanda, Malawi, Zambia, and the rest, as you can see. And through this introduction of HPV, we had over 1 million women screened, and this is 70% were screened through general population, and 30% are women with HPV. And over this, we have close to 100 sites offering integrated service delivery. Yeah, and then in terms of screening, we have over 700,000 women screened through VIA, and just under 350,000 women screened through HPV. And in terms of the balance between clinician-collected and self-collection, we have a 50-50% split. And through conversations, we've been able to reduce this test to little over $10, $9. This signifies a 40% price reduction in terms of that. And then 87% of the women who are screened positive have received treatment, and 96% of these sites have been equipped with on-site treatment, so that the clients don't need to move far and about to get access. And 83% of the women have been referred to, who have suspicious cases, have been referred to further visits. And on to my last slides, we still have substantial work which needs to be done, because the work which has been done so far is only a small percentage of that. And through collaboration and through all the partners, all the donors, all the key policy makers who are here, we still have some ground to cover in terms of getting all the eligible women to get access to screening. Thank you.
Thanks so much, Lance, for sharing those impressive coverage results. I now want to introduce Rebecca Novak, who's an infectious disease epidemiologist focused on HIV and HPV infections in sexual and gender minorities in Nigeria. And she is going to talk about an MSM anal cancer program in Nigeria.
Good afternoon. Thank you for inviting me. This is work that I'm speaking on behalf of the trust cohort in Nigeria as well as the trust team. I have no conflicts to disclose. Just to set some context, Nigeria here is in West Africa with the green and white flag. It's one of the most populous countries in sub-Saharan Africa. And currently in the general population, the prevalence of HIV is about 1%, but for men who have sex with men and gay men, the prevalence estimates recently are around 14 to 25%. And it's very challenging to get this marginalized population into care due to the stigma and the criminalization of same-sex practices. So we started in 2012 to try to work around the challenging environment, and we set up 2 community-based clinics that were specifically geared towards men who have sex with men to be able to come in, get tested, and to get treatment. It also had STI testing as well. And so we developed these 2 clinics. This is the one in Abuja. And it ended up being a very successful care model. We had 2,000 MSM enroll into our cohort. 31% of them were newly diagnosed with HIV. We were able to get them onto care, and we were able to get 71% or so achieved viral suppression. So given, and then we had also done some preliminary work to look at high-risk HPV infection in the cohort, and we did find that 70% of those living with HIV had high-risk HPV. So with this pretty successful care model with a protected environment, we were curious as to whether we could nest in an anal cancer program. We weren't sure how it was going to be received by the community, and we weren't sure if anybody would be interested in engaging with it. So we did a feasibility study that was for a year in 2016 to see if we could train our in-house physician to do screening not screening, but detection of HSIL with high-resolution endoscopy. And our one-year study was split into 2 phases. We had the training phase, which was to screen up to 100 people, 100 persons, for learning to identify high-grade disease. And the physician had a little bit of trouble in the first 100 screenings, but as we progressed into the pilot phase, we start to see an increase in low-grade lesions, but we only saw 6% of HSIL. And Dr. Plesky already showed the high prevalence of HSIL for persons living with HIV. So we had a little bit of challenges detecting high-grade lesions. To better understand the learning curve, we looked at the prevalence of detecting any dysplasia over the cumulative number of persons screened, and you'd expect that as you're learning, your growth curve will go up, and then you'll flatten out when you're starting to see the same detection rate for any dysplasia. Now, what we would have hoped was that we were detecting enough high grade and we could have watched the S-shaped curve. But in fact, we had challenges with detecting high grade. But there were two main things that came out of the feasibility study. There was very high uptake. We did over 500 screenings in a year, and the study staff was very enthusiastic and was working in a very challenging environment. We lose electricity. We're different time zones for mentoring, and they continued on. So there was a lot of enthusiasm, but there were a number of barriers that we identified initially with screening. So, and then the other thing at the time was we weren't sure if treating HSIL was actually going to prevent anal cancer, so we were waiting. And luckily, Dr. Plesky's anchor study was able to show efficacy, and that was the EBI. That was the evidence-based intervention for us to move forward. We already knew that we had some barriers, and we now had an evidence-based intervention. We can see that you can successfully treat high grade in a randomized clinical trial. How do we then bring that to a low to middle income setting? So we are building off of that earlier work. We're going to incorporate implementation science frameworks to really understand the barriers, see if we can modify the training in a way so it's more readily adopted and we can implement better. So this study has just started. And we started enrolling and screening in May. And I just wanted to show some of the preliminary data that we're seeing for the first 50 persons that have screened. These are all persons living with HIV. 44% of those who've enrolled in the first 50 previously engaged in our feasibility study, so we thought that that was reassuring because they re-engaged. The median age is 32, with an interquartile range of 31 to 35. And when we asked them if they're worried about anal cancer, because we wanted to see what the community feels about the program, they could rate their worry from 0 to 100, and 70% reported 75% and above were concerned about anal cancer. We are also monitoring in the screening how they're feeling about the procedure. Are they anxious? We ask them on a scale from 0 to 10, from strongly disagree to agree, what their level of anxiety was about the procedure, and the median score was a 4. We're also trying to make sure we take into account levels of pain as we're doing this, because these could potentially be barriers. And on a scale from 0 being no pain and 10 being severe pain, the median report was a 2. We have some work to do. 76, they're all persons living with HIV. 76% have been biopsied, but according to Ian's guidelines, they should be at least getting 2 biopsies. And so we got some learning to do, but initially they're doing the majority of biopsies as a single biopsy. 28% have had multiple biopsies. And just to show some preliminary data, this is comparing the new study, the impact study, compared to our prior work. And you can see, as expected, that based on the operator, the one doing the screening, you can have variability. So even within the first 50 screenings, we're seeing a higher detection of dysplasia, particularly HSIL. But if you think about the learning curve, which is another thing that we're kind of monitoring, we've actually gone up to 100 screenings as of the past couple days. And if you look at their you look at the prevalence of HSIL over the cumulative number, they're really hovering at 13%. So it was 12.9 at the end of May, 13% at the end of June, and we're at 13.1 for July. So we are now entering into the phase where we're going to start assessing barriers and facilitators and really diving in and using the implementation science conceptual frameworks to help us formalize our evaluation. And so with that, I'd like to thank all of our collaborators. This is it's a huge team. I can't take credit for it, so thank you.
Thanks so much, Rebecca. Great to hear about an anal cancer screening program in the African region. Last but not least, I will introduce Mary Poynton, who's a clinical epidemiologist at the Kirby Institute, who is leading several anal cancer screening trials, and she's going to talk about moving towards an anal cancer screening algorithm.
Good afternoon, everyone. I'd like to thank the organisers for asking me to present, and I'd like to acknowledge the traditional custodians of the land that we're meeting on, the Yagara people and the Turrbal people. So today I'm talking about developing an anal cancer screening algorithm. I have no conflicts of interest. Oops. So I'm going to present a summary of the available screening methods and the anal high-risk HPV prevalence in people with HIV. I'll discuss whether we can use high-risk HPV testing as a screening test and present some results from a pilot study we've been conducting in Sydney. So anal cytology is the most widely used and most evaluated screening test. It's not standard of care as yet, but as Joel mentioned, guidelines on anal cancer screening are very promisingly soon to be available. But Megan Clark and her colleagues undertook a meta-analysis of anal cancer screening methods, and this meta-analysis found that a sensitivity of 81% for cytology and a fairly low specificity of 61%. Like in the cervix, anal high-risk HPV testing is more sensitive than cytology, but this comes at a cost of specificity. So it's clear that we need some additional triage of those people who test high-risk HPV positive to improve this specificity. The meta-analysis also looked at co-testing, so using cytology and HPV testing, and a positive to either was classified as positive. But the meta-analysis showed that this provided no additional benefit to high-risk HPV testing alone. And the specificity was even lower at 33%. There were not enough data to assess initial testing by high-risk HPV testing with triage to cytology of those people who are high-risk HPV positive. But this may improve specificity, but again, may be at a cost of sensitivity. There have been a number of meta-analyses looking in anal high-risk prevalence in people with HIV. Most of the studies are in gay, bisexual and other men who have sex with men. And you can see here, I'm going to use my pointer, about 3/4 have any high-risk HPV detected in the anus, with about 28% having high-risk HPV-16, which is the most common cause of anal cancer. Looking at heterosexual men with HIV, it's about 27% have any, and about 17% with high risk with HPV-16. In women with HIV, up to 36% of women who are diagnosed with H will have concurrent HPV-16, and almost half have an anal high risk HPV. This slide shows the cumulative incidence and clearance again of HPV-16, the most important HPV type with anal cancer. And you can see on graph A, this is looking at incidence of HPV-16. And just looking at the top line here, this is MSM with HIV, and you can see how much more common incident HPV-16 is in this group compared with other risk groups. And conversely, looking at clearance of persistent HPV-16, again looking at a follow-up to 2 years, over 60% of MSM with HIV will have persistent HPV-16. So it really shows that the important difference with HPV-16 in people with HIV. So that shows the viral persistence and the importance of the virus. And how does this translate into disease and clearance of high-grade disease? So we undertook the SPANK study in Sydney. It was a community-recruited study of gay and bisexual men. There we had 1/3 of the population with HIV. They were an older population, and very few had been vaccinated at baseline. So the important finding from SPANK for this talk is looking at the clearance of high-grade disease. So clearance this is without treatment, so spontaneous clearance, about 1 in 4 lesions per year cleared spontaneously. But here, if you had HPV-16 at baseline, you were half as likely to clear your high-grade disease. So looking with all this information, could we use high-risk HPV testing as anal cancer screening? So we've seen that it's highly prevalent, and really that makes it clear that it's too prevalent to use as a simple one-off screening test. As we know, most anal cancer is caused by HPV-16, so it stands alone, whereas HPV-18 does not, for its low clearance rate and high cancer risk. And so it needs to be viewed differently to the other high-risk HPV types. And then it's important to differentiate those high-risk HPV infections because they are so prevalent that will be associated with high-grade disease from those that are not. So to further explore this after we finished the SPANC study, we looked at could we develop a potential algorithm for anal cancer screening to reduce the referral to the expensive, invasive, high-resolution anoscopy test. Using the model of cervical cancer screening, we broke this into groups. So again, if you do an anal HPV test, and this is using the SPANC data, so in men with HIV in the SPANC study, we had 14% would have no high-risk HPV detected. So they could then be just put into routine screening at an interval to be decided. We had over a third had HPV-16 detected, and these people would be referred directly for HRA. But then we have this group of about half who don't have HPV-16 but have another type detected. And this is where we are exploring the use of a triage test and then looking at sort of interval testing and how we decrease the referral for HRA. So we've undertaken a pilot study looking at this in Sydney, and this is the REACH study. So this is the study in people living with HIV in Sydney. We were interested in looking at a potential triage test as well, so we chose the P16, Ki67 dual staining test, and we tested everyone for that. So we enrolled 136 people from clinics around Sydney, 135 men and one transgender woman, median age of 54. The vast majority identified as homosexual or queer, and only one person wasn't on antiretrovirals. And again, HPV vaccination was rare. We had 133 with valid tests, and you can see here that about 29% were high-risk HPV negative. 6 of these were P16, Ki67 positive, so we referred them for 12-month testing. And 32 were negative for P16. So these people exited the study. Looking over here, we had about 30% who had HPV-16. And of those who attended for a high-resolution anoscopy, we had almost 2/3 had high-grade disease, so very high prevalence of disease in this group. Of the remaining 41.5% with a non-16 high-risk HPV positive, we got them back at 12 months for repeat testing. So these are the results from the 12-month visit. We had 61 due and about 3/4 attended, and this lost to follow-up. So about 25% were lost to follow-up at this stage. Of those with HPV results available, we had about 1/3 who could then exit the study. They didn't need an HRA because they were negative at this stage. We had 2 incident HPV-16, and then about 63% had the same genotype. Oh, God, too excited. Had a non-16 type. So of those who attended for their HRA, much lower risk of HSIL. So only about 18% had HSIL. So in conclusion, we felt that anal high-risk HPV testing is a potential screening method for anal cancer in people with HIV. If people are negative, you can reassure them and retest, and perhaps at 3 years, similar to cervical testing in people with HIV. If you have a positive HPV-16, immediately referred for HRA. And if you have another high-risk positive, retest to see if you have chronic, like persistent infection with that type. Additional triage tests may improve the specificity, so cytology, dual staining, DNA methylation, and DNA methylation does appear to be the most promising sort of biomarker, additional triage testing, showing higher diagnostic performance for HSIL detection. We're exploring screening using self-collected swabs, as has been discussed with the cervix, in that self-collection may improve uptake of screening and improve retention in screening programs. And we're thrilled that we received a 5-year philanthropic grant from the Glendenbrook Foundation, and this is our group in Sydney, and we are conducting a national program for screening and treatment to prevent anal cancer in people with HIV. So that work is just commencing. And I'd just like to thank the SPANC and REACH participants and acknowledge the many, many colleagues and people involved in this work. Thank you.
Thanks so much, Mary. We now can open this session for Q&A. We've heard a real sort of range of innovative approaches to both cervical and anal cancer screening in a range of settings. And I think sort of what's striking really is that there are many commonalities across these diverse settings. We heard a lot about the importance of stakeholder engagement and involvement. We have heard sort of varying approaches to demand creation, the importance of sort of needing to manage commodities, but also this issue of healthcare worker training and turnover, the importance of sort of integration and alignment, particularly with HIV programs as a way to identify a higher risk population. Also kind of heard echoes, I think, for HIV treatment of the need to demedicalize and to go where people at risk are, rather than sort of drawing people into health centers. And I think I also heard the importance of really how health information systems guide decision-making and really, I think, generate support for these programs. So a really kind of wealth of experience and expertise. And I'm going to thanks, Andrew, for kicking off the questions and for getting us started, but would welcome you to come up to the mic to address your questions.
By the minor variations between programs, as you mentioned, a lot in common, but some, and the situation in a upper middle income country like Malaysia, where people were referred to specialists in a specialist clinic for treatment in the Western Pacific, and I think elsewhere where treatment was done on the spot. I suppose that raised for me the issues of training and how easy is it to train relatively non-specialists in the treatment, and is it as good or acceptably good when compared to treatment in specialist hands?
Not sure if this is working. I mean, I think really the foundation, the service in PNG, in Vanuatu, and also the support that's now being provided. The group is also actually helping to support teams in Tuvalu and other countries with moving forward, in fact. But I mean, that expertise is really based on a nurse-led or a midwife-led service. So, because there's simply, I mean, for example, in Papua New Guinea, we simply don't have enough. There's not enough medical staff that the gynecologists, we're trying to preserve not only their time, but also some of the senior nurses' staff time, so that they can use that time to provide the best possible care to those that test positive or those that are referred with a suspected lesion. So the whole service has really been, and there's been enormous support in all the countries where we're working to move in that direction. That said, it means that the training in thermal ablation, in our experience, the training in that is not so difficult. The main training is really around the visual assessment. It's making sure that that staff are accredited as competent locally by experts in country, and that they're able to conduct the eligibility assessment so that they know exactly who could be offered treatment at point of care and who should be referred. And that's been monitored incredibly closely throughout. During the earlier field trials, there's several field trials, even when we were doing VIA with cryotherapy, etc., but particularly also, continuing now. We're also, with Marion's support and support through an international, there's an international accreditation scheme and a training scheme to actually support countries and experts within country with conducting LETs, large loop excision. And so we're connecting into that program to ensure, this has come at the request of partner countries, to ensure that people are able to access that network. They become accredited mentors in their own right, and they can establish their own training and take that forward. And I feel awful that Paulus and my other colleagues aren't here to actually say that themselves, but it's been on their behalf. I think that transition and that skills transition has been very, very successful. Yeah.
Can I make one more point too, which is that you touched on VIA, but that VIA workforce, so I think we all think that VIA is not a good enough triage, or screening test, but that VIA workforce are very, very skilled at seeing the cervix, and that's how the transition was made. And I think it's really important because they're committed people, and we want to make sure they know they're valued, even though that technology is probably not the best technology. So they're very good at assessing the cervix.
Yeah, absolutely. Thanks. Did anyone else want to? Yeah.
Oh, sorry. So maybe from our context, which is now in the low, middle, and income countries, we find that we have to really understand the scheme of work for the different cadres of professionals. Because as we saw in Kenya, as we began the project, we didn't know that the nurses with adequate training would be able to do something like, let's say, for example, colposcopy. Yeah, it was until later on in the project that we went back to the council which regulates nurses that we saw indeed with training they can provide that, and that just increases the pool of medical personnel who are able to provide these services. So in the different areas, contexts that you work with the regulators of the medical professions, and you'll be able to know at what point does this start and this stop, at what point does this start, because most of them they really, really overlap, and you can increase the scope of the number of people who can provide the service. Thank you.
Richard Hillman from St Vincent's in Sydney. Firstly, a comment for Rebecca. I just think you're doing absolutely amazing work there in one of the most difficult populations to study. And I commend you for being so honest about the difficulty identifying high-grade disease in the anal canal. But I also want to broaden it because part of this has been answered already. We're about 20, 30 years behind the cervix, and you've kind of learned about VIA and trialed it and got staff who are used to it. I wonder if there are some less sophisticated technologies we can use, maybe like a version of VIA, that will get us on that journey so that ultimately we will have fantastic HRA services in places like Nigeria. But obviously the longer we wait to introduce these studies, the more people are going to succumb from what is essentially often an incurable condition in low-resource countries. So I wonder what the panel, particularly Andrew Valley, are there any gems that you can share with us about your enormous experience in resource-poor environments that might help us to get on that journey about improving our diagnosis of anal HSIL?
If it's specifically about, when we first, I go back a bit, in 2009 there was a ministerial task force in Papua New Guinea that recommended that it found that the PAP test program, despite the enormous efforts from an enormous number of people, just basically wasn't able to achieve population level screening. Couldn't achieve the follow-up, the same kind of experience we've seen in so many countries around the world. And so we thought, let's try, we've heard about what other people are doing in Tanzania and Bangladesh, and we'll try VIA. And we're all very excited thinking that visual inspection would work. And sadly, it didn't. So we added HPV, and even with HPV in a combination with VIA, again, it didn't really work. So it was really very unhelpful in terms of the identification of so-called aceto-white lesions in the cervix. Really, they're not sufficiently associated with disease to make that a suitable triage tool. Certainly not in our setting. There's been a lot of discussion around whether they would in future be used as a suitable triage tool. Personally, I don't believe that they will in PNG for the cervix, because we've already seen that the sensitivity falls away dramatically when they're used in combination. So unless there is very strong evidence that the celia white staining in other places, so if you potentially there's an opportunity to use that as a way of starting screening at scale for anal cancer, anal intraepithelial neoplasia, I just feel sadly that would be, although it'd be great for in terms of getting something out there, it's just whether or not we would all feel that the evidence is likely to be enough to make that a credible program.
And can I say too, I think part of the lesson is not hanging on to something that's not working. And the longer it goes on, the more stakeholders you've got that have got an interest in keeping something that's not working going. So while it's not a technological lesson, it certainly is a sort of political resourcing lesson.
It just puts a little, can you hear me? It just puts a little pressure on EANS because I think that there's a great resource and a great community. And I think networking our physicians, oh, you can't hear me?
Just need to be close.
I think networking our physicians with the greater community, I think we've got great potential. They're very excited and very eager to learn. And I think having more visuals and in using the EANS network for the team, I think we will actually identify some of the challenges and be able to move forward faster. I think a lot of it's doing it, in a very remote setting without much mentoring, really getting access to a lot of things and seeing things and having discussions. And we're going to try to see if incorporating the pathologist is very passionate about his work, incorporating that and having the team kind of come together. So right now, the internal team right now is doing a CFIR card game to identify the particular barriers. And so we're going to, they're all excited to identify the barriers, and then we're going to try to see if we can map some strategies to kind of overcome those.
I'm just wondering if anyone's involved or know of any results using artificial intelligence for the triage bit for either anal or cervical cancer? Anyone? No. Okay. Maybe that's one area we need to invest in.
Yeah, maybe I can mention something. Because so as Chai, we were piloting something called the AVE back in 2 countries in Africa. So it's I don't know if many of you are familiar with it, but it's just using a smartphone, any smartphone, Samsung or even an iPhone, download an app. Then this app has a repository of very many cervixes, both positive, negative, suspicious cases, and all that. And so with more practice, just the way AI normally works in whatever platform, with more information it's fed, it becomes more and more sharper. Yeah, so it's still in the pilot phase, and we're still working just to refine it. And once it's refined, and once it's approved, then it will be put out just to try it out and see whether it matches the actual diagnosis. Yeah.
And I think maybe just to add to that, I think one of the issues with the machine learning and the AVE is just that it hasn't had lots of images or experience, particularly with people living with HIV. So kind of being able to build that database is going to be important. There's a question at the back.
Thank you. Nitya Panupak from the Institute of HIV Research and Innovation in Bangkok, Thailand. First of all, very beautiful presentations from all of you, especially from Dr. Novak and Dr. Poynton. My question is that, congratulations on the effort to set up the anal cancer screening in Nigeria. That's really wonderful. My question is, number one, we do know that has been very challenging to try to build the network of HRA physicians everywhere. And in Asia, I believe that there are less than 10 people, not counting Australia, of course, physicians who are trained and who still continue to practice HRA. So my first question is how the program in Nigeria plan to sustain those who are trained HRA physicians to keep them on doing this, because it's really time consuming, and you couldn't expect someone who is an ID physician or OBGYN or dermatologist to continue doing this on a day-to-day basis. That's number one. Number two is that related to the NO-HyCil screening algorithm that Mary has demonstrated to us. I think we have to admit that the majority of countries in the world would not have HRA physicians, HRA capabilities in the near future for sure. So, and also like to wait for new biomarkers to coming up and assume that it will be at a scalable way of applying this into the algorithm worldwide. I think that's probably too ambitious. I just wonder whether there could be any algorithm just looking at high-risk HPV repeatedly, assuming that we don't have HRA, assuming that we don't have any other biomarkers or even cytology, and see how we can further like optimize the use of high-risk HPV screening for anal cancer screening algorithm. Thank you.
So, can you hear me? Okay. In terms of training for the HRA, yes, it's a big investment. I think we're going to just do the best we can. Everybody is very enthusiastic and eager to have it, and by engaging somebody from the community, they're incredibly devoted. And so, I can't predict how many people I can get trained, but I'm going to just do the best I can. So.
Yeah, and similar in Australia, we have it's a long road ahead for us to develop adequate screening, and we have very strong links with our community groups who are amazingly, they advocated for the first HRA clinic in Sydney. The Positive Life New South Wales, they basically made that happen. So we work very closely with affected communities. Secondly, this is the Australian model that we're working the MSAC to get anal HPV testing funded by the government, and we'll also work to get HRAs funded by the government. So people get payment, clinicians get payment that will make them excited to do it. They'll get paid for it, so they might do it. But obviously in settings, and it's really true, and that's why the CDC guidelines are very important, because they're saying basically don't screen unless you can perform an HRA. So we are so far, we've got so far to go. And I think doing a digital anal examination, you identify an anal cancer early. If you identify an anal cancer at less than 1 centimetre, you've got almost 90+% chance of surviving it. If it's over 3 centimetres, that goes down to about 40%. So I think at this stage, what we really need to do is get that message out, is just for everyone living with HIV, their clinicians should be doing a digital anal rectal examination. And we're very interested in doing that repeat testing with HPV testing. We think that's the way to go. If you have 16, that's the main one, but then looking at how we can limit the number of HRAs by retesting and rescanning and seeing if that is just an incident infection that's going to clear, or whether it's persistent and going to be associated with disease. Thank you.
Mary, I just want to expand a little bit more on what you just said, which was, I think you were asking whether there's some way around getting really optimal training in HRA. And the answer for now is no, until we have a systemic therapy. Because we have to remind ourselves why we're doing this. We're trying to treat HSIL to prevent cancer. And the only way to identify the lesions to treat would be to have good ability to detect the HRA. So in a fantasy world where, for instance, you give an injection, say it's an immunotherapeutic against HPV-16, doesn't matter whether there's an H cell at the bottom of a crypt that you can't see, the immune system will take care of it. But we're not there yet. We're still in the stage of targeted ablation. And so the purpose of doing HRA, really, when all is said and done, since this is cancer prevention, is to find lesions to remove to prevent progression.
Well, I just want to wind up the session by thanking all our panelists for their excellent inputs. It's really been a round the world tour of wonderful programs that really are ensuring that we can increase access to cervical and anal cancer prevention. So thank you very much to all of you, and we can break for tea.